Most people never think about what their body is doing during sleep. They close their eyes, they drift off, and they assume that because nothing is happening consciously, nothing of consequence is happening physically either. But here's what cardiologists and neurologists have come to understand through years of careful observation and research. The position in which you spend 7 or 8 hours every single night is not passive. It is not neutral. It has a direct and measurable relationship with the pressure inside your cardiovascular system, the quality of blood flow to your brain, and in certain specific circumstances, the risk of events that most people assume have nothing to do with something as ordinary as how they arrange themselves on a mattress. And there is one sleeping position in particular that cardiologists are paying close attention to, one that a surprisingly large percentage of people over 60 default to every night without any awareness of what it may be doing to their cardiovascular system while they sleep. Stay with me through this entire video, because what I am about to share is the kind of information that most people never receive until after something has already gone wrong. And understanding it now, tonight, before you go to sleep, could genuinely matter. Let us begin with something most people have never considered. Have you ever woken up in the morning with a headache that was not there when you went to sleep? Or felt a strange heaviness behind the eyes in the first few minutes after waking? Or noticed that your heart seemed to be working slightly harder than usual in those first moments of consciousness? Most people attribute these sensations to poor sleep quality, to stress, to dehydration, or simply to the general discomfort of aging. But cardiologists pay close attention to morning symptoms, because the hours of sleep are not metabolically quiet hours for the cardiovascular system. They are hours during which the body is performing some of its most critical maintenance work, and the conditions under which that work happens are directly influenced by body position in ways that most people have never been told. Think of the cardiovascular system during sleep like the maintenance crew of an old house working through the night. The pipes need to be checked, the pressure needs to be balanced, the circulation needs to reach every room. If the house is tilted at the wrong angle, certain rooms receive too much pressure and others receive too little. The crew works harder to compensate, and by morning, the system shows the strain of a night spent working against its own architecture rather than with it. This is very common after 60. Most people have never connected their sleeping position to their cardiovascular health. That connection is exactly what we are going to build clearly today. Now here's where it gets genuinely interesting, and where the specific position cardiologists are most concerned about enters the picture. Sleeping flat on the back, what is medically called the supine position, is the position most commonly recommended in general health conversations. It feels neutral, it feels symmetrical, it feels like the position that should cause the least strain. But for a significant portion of people over 60, particularly those with any degree of cardiovascular vulnerability, sleeping flat on the back creates a specific set of conditions that deserve serious attention. Here is the mechanism that most people have never had explained. When a person lies flat on their back, the full weight of the body, including the abdominal organs, the diaphragm, and any excess weight carried around the midsection, presses downward onto the major vessels that run through the chest and abdomen. The inferior vena cava, which is the large vein responsible for returning blood from the lower body back to the heart, can experience partial compression in this position. When that compression occurs, the volume of blood returning to the heart with each cycle is reduced. The heart compensates by working harder, and in a cardiovascular system that already has less reserve than it did at 45, that additional nightly workload accumulates in ways that are invisible during the sleeping hours, but felt in the waking ones. But this is only part of the story. Here is the warning that most people find most surprising and most important. Sleeping on the back significantly increases the likelihood and severity of obstructive sleep apnea in people who are susceptible to it. And the connection between sleep apnea and stroke risk is one of the most direct and well-documented relationships in all of cardiovascular medicine. In the supine position, the tongue and soft tissues of the throat fall backward under the influence of gravity. In a younger, more muscular airway, this is compensated for naturally. But after 60, as the muscle tone of the upper airway naturally decreases, this backward displacement of soft tissue can partially or completely obstruct the airway repeatedly throughout the night. Each obstruction causes oxygen levels in the blood to drop. The brain, sensing the oxygen deprivation, sends an emergency signal that partially rouses the sleeper, just enough to restore the airway, without the person ever reaching full consciousness or remembering the episode in the morning. Now, here is what makes this so directly relevant to stroke risk. Each episode of oxygen deprivation triggers a stress response in the cardiovascular system. Blood pressure spikes suddenly and significantly. The heart rate surges. The blood vessels constrict. And this pattern, repeated dozens, sometimes hundreds of times per night in people with moderate to severe sleep apnea, creates exactly the kind of sustained cardiovascular stress that elevates the risk of the arterial events that cause stroke. You are not alone if this is the first time anyone has drawn this connection for you this clearly. Most people with sleep apnea are told it affects their sleep quality. Very few are told how directly it connects to cardiovascular and cerebrovascular risk through the specific mechanism of these repeated nightly pressure surges. That is why you may notice that the people most at risk from back sleeping are not necessarily those with the most severe underlying heart disease, but those with the undiagnosed, unmanaged airway vulnerability that back sleeping activates every single night. Now let us talk about what the research and clinical observation actually show about the relationship between sleeping position and stroke specifically. Several studies examining stroke patients have found a notable pattern. A disproportionate number of strokes occur in the early morning hours, between approximately 3 in the morning and 9 in the morning. This window corresponds precisely with the period during which sleep is lightest, during which the body is preparing for waking, and during which the cardiovascular changes associated with the transition from sleep to wakefulness are most pronounced. In people who sleep on their backs and experience repeated episodes of oxygen deprivation through the night, the cardiovascular system arrives at that early morning transition window already stressed, already carrying elevated inflammatory markers, already operating with blood that is slightly more prone to clotting due to the physiological changes that accompany repeated arousal from sleep. Think of it like a machine that has been running under excess load all night. By morning, the components are warmer than they should be, the pressure in the system is higher than it should be, and the margin for additional stress is narrower than it would be if the machine had spent the night in its optimal operating conditions. The early morning is when that narrowed margin shows its consequences most visibly. This is very common after 60, and understanding this pattern is what transforms a seemingly abstract piece of cardiovascular science into something immediately practical and personally relevant. So, what does the evidence suggest about safer sleeping positions, and what practical steps can be taken tonight? The position that most consistently shows benefit in the cardiovascular and sleep medicine research is side sleeping, and specifically, sleeping on the left side. Here is why the left side matters specifically. In the left lateral position, the heart sits in a slightly more natural anatomical position within the chest cavity. The major vessels responsible for circulation are under less compression from surrounding structures. The airway geometry is significantly improved compared to the supine position, reducing the likelihood and severity of the airway obstruction that drives sleep apnea episodes. And the lymphatic system, which runs primarily on the left side of the body and plays a role in clearing inflammatory compounds from the tissues, drains more efficiently in this position. The example that makes this most tangible is simple. Most people instinctively roll to their side when they feel physically unwell during the night. The body already knows, at some level of deep biological intelligence, that the lateral position provides greater physiological ease than lying flat. That instinct is not random. It is informed by the same anatomical realities the cardiovascular research is now confirming in more precise clinical terms. Now here is the practical guidance that cardiologists and sleep medicine specialists most consistently offer. A pillow positioned behind the back during side sleeping prevents unconscious rolling onto the back during the night. This is one of the simplest and most immediately accessible interventions available, requiring no equipment, no expense, and no medical intervention. Simply place a firm pillow against the back before sleep. If the body begins to roll during the night, the pillow provides physical resistance that disrupts the movement without fully waking the sleeper. Elevating the head of the bed slightly, either through an adjustable base or through placing something stable under the head-side legs of the bed frame, reduces the pressure that horizontal positioning places on the cardiovascular system and further reduces the gravitational component of airway obstruction. Even a modest elevation of a few inches produces a measurable difference in the cardiovascular conditions of sleep. Keeping the sleeping environment genuinely cool, between approximately 65 and 68 degrees Fahrenheit, supports the natural drop in core body temperature that the cardiovascular system depends on to enter its most restorative sleep stages. When the environment is too warm, the body never fully reaches those stages. The heart rate remains elevated through the night, and the cardiovascular benefits of sleep are substantially reduced. Avoiding alcohol within 3 hours of sleep is particularly important in this context, not just for sleep quality in general, but specifically because alcohol dramatically worsens upper airway muscle tone, significantly increasing both the frequency and severity of the obstructive episodes that make backsleeping most dangerous for the cardiovascular system. And hydrating adequately through the day, not excessively close to bedtime, but consistently throughout the waking hours, keeps the blood at a viscosity that supports healthy nocturnal circulation, rather than the slightly thicker, more sluggish flow that mild dehydration produces, and that increases clotting risk during the cardiovascular stress of sleep apnea episodes. So here is where everything comes together clearly and simply. Sleeping flat on the back increases the compression of major blood vessels, worsens upper airway obstruction in people susceptible to sleep apnea, triggers repeated nightly cardiovascular stress responses involving blood pressure surges and oxygen deprivation, and contributes to the inflammatory and clotting conditions that elevate stroke risk, particularly in the early morning hours when the cardiovascular system is most vulnerable to the accumulated strain of the night. Side sleeping, particularly on the left side, reduces all of these mechanisms simultaneously. A pillow behind the back, a slightly elevated head position, a cool sleeping environment, no alcohol close to bedtime, consistent daytime hydration. These are not dramatic interventions. They are quiet, consistent, nightly adjustments that change the cardiovascular conditions of sleep in ways that accumulate meaningfully over weeks, months, and years. If you snore regularly, if you wake unrefreshed despite adequate hours in bed, if you experience unexplained morning headaches or heart rate irregularities upon waking, these are signals worth bringing directly and specifically to your doctor, with sleep apnea evaluation named as the explicit reason for the conversation. Your cardiovascular system does not rest during sleep. It works. And the position in which it works through those 7 or 8 hours every night is not a trivial detail. It is one of the most consistent and most modifiable variables in the entire landscape of cardiovascular risk after 60. Have you ever noticed a difference in how you feel in the morning, depending on the position you slept in? Does this connection between sleep position and heart health surprise you? Share your experience in the comments below, because what you share here matters, and someone in this community may find exactly what they needed in your words today.